Thank you all for your presence and good morning. So, Jeanne, if you don't mind, I'm going to start with you to give a frame to this conversation. Can you tell us more or less what is the share of the health system in the French carbon footprint, and what does it mean decarbonating a health system? Which are the 4 or 5 main elements for that? Because there's no plan, really. Well, thank you, Jean-David, and thank you for this invitation. The impact of health systems on environment is obvious when you think that the health system in France represents more than 11% of the GDP, 17% in the US. So you have to understand it's an industry like any other, which generates quite a lot of CO2 emissions. The exact calculations were done in the US. In France, recently we tried to calculate that, and we feel it's about 5 to 6% for OECD countries and 10% for CO2 emission for the US. What's important to understand is that the environmental impact does not only come from CO2. There's other types of impacts that can be measured and are usually measured, means from abiotic resource depletions, fossil fuels, the ozone layer, the human toxicity on water, oceans, eutrophication, and all the impacts. And for these impacts in the OECD countries, the health system represents 10%. So we see it's a major impact. Now, if you look at the health system, and I talk mainly about the hospital, which is what I know best, when you look at the carbon balance that were calculated with the 3 scopes, the first one that comes up is transportation. So in hospital, we understand that transportation is important. You transport patients, visitors, staff, the whole logistics. And there are solutions for that, which are specific, because you can talk about teleconsultation or shared transportation for patients. The second point, depending on where the hospital is located, whether you're in the city center or in the country, the second point is energy. We know the state of obsolescence of our health establishments. We operate thousands of square meters that are very badly isolated. We all remember a night watch when you have the radiators on and the window open. We all remember that. So there are 3 actions for the decarbonation of hospitals, including the insulation of the buildings, the fact that they're really there's a loss of thermal energy. Second point is procurement. Procurements represent a third of the spending in hospitals, and it can be medications, it can be medical devices. And for the past 30 years, we have now come to 100% single-use devices, a lot of plastics in the devices, that with the endocrine disturbers, heavy procurements, heavy spending, and there's no list of specs for decarbonated procurement now. And then you can talk about waste, but no need to dwell on that, because this is a topic that has been illustrated much more with the face masks, for example, during COVID. But this is one of the topics that is broached in Action 14 in the Ségur de la Santé. And more specifically, for example, for us, anesthesiologist resuscitators, we use gases that are directly within Scope 1 of greenhouse gases, and they go directly into the atmosphere, so we should see how we can reduce their use and their environmental impact. Thank you very much. We can see it's very complex. Étienne, when you were at APHP or now at CAPGEMINI, was it an emerging topic, or are you asked to decarbonate some establishments. Yes, at CAPGEMINI we do that, and when I was at APHP, it was different, but the message we must present is that it's an issue of system. We are in a Scope 3 activity. I don't know if you know that, what it means. It means the systemic part, the indirect part. If we were technocratic, we would say that the topic is medication. So in the health system, out of 33 million tons, 20 million come from the production of medication and 50% are imported. A quarter of the carbon balance of the planet comes from the US, so, which is really represents the world economy. Now, in my career, I've been asked to study the cyclamen system, which was collection of unused drugs. And there was a system where you could take your medications that were unused in the pharmacies. In fact, whether you give it to the pharmacist or to the put it in the dustbin, it ends up in an incinerator. So the idea is to see how you can connect this system to other systems like waste collection, transportation, materials. When you build a new hospital, what quantity of wood or concrete or whatever. What I could conclude is that we are nowhere in our reflection. The only study has been done by an American association in France. The NHS has a great decarbonation strategy, which is highly decentralized. So the British system has a great and a clear decarbonation plan. It is paying fine because it is not within its carbon balance. So the US has a strong action announced by President Biden last month. What I know in the French system, which is the culture of free lunch, health transport, single-use equipment, food in the hospital room, food for the patient. French pharmacies may be the lost temples of plastic on this planet. We built our system so much around the free access to care that it is difficult for us to impose constraints that exist in other sectors like the pharmaceutical industry in order to control the issue of carbon. And this is at the very core of the issue. We must reintroduce the carbon issue everywhere, and not only carbon. We use gases for anesthetics, which have much more important consequences on climate warming than, for example, fossil fuels. So we have to work on this. My key message would be we're running late in France. We haven't got the right info and observations. And in order to get there, we shouldn't split everything. We should reintroduce the issue of carbon balance everywhere in the system. So would you say the hospital is the worst thing in terms of energy balance, or is there worse? Cécile PRÉVIEU. Well, there's always worse. All the health and medical social establishments represent about 15% of the tertiary sector, but it's a dynamic sector which increases by about 10% a year as far as energy consumption is concerned. You mean of French hospitals? Well, I mean that each establishment is evolving by about 5 to 10%. I would say about 10% a year. So there's a lot of control to be done there. And also it has a carbon impact because energy is within Scope 1 and represents 16% of the global impact of the health system. So it's not negligible. So what can we do to improve the carbon intensity or energy intensity? Well, there's three elements, three pillars. First of all, energy renovation of buildings, less carbonated energies, insulation of the built environment. These are heavy programs. A few initiatives have been launched to try and massify these renovation work. For example, within the Pays de Loire and Nouvelle-Aquitaine, there's a consultation between the regional health agencies, and there's a program, but we're talking about pilot tests. We're talking about a few, 2 and 2 million, so 4 million in total of subsidies. It's only the first step. How can we launch a massive renovation program by coordinating the programs? There's the other pillar, which is energy efficiency. How can we reduce the consumption of these establishments? So we're offering energy performance contract, committing to reduction in consumption and CO2 emissions over time. These contracts represent 5 to 8 years in order to get an impact afterwards. And then how can you green the energy? Get green electricity with local production, solar panels on the roofs, connection to solar fields or hydroelectricity. You can also connect the establishments to heat networks, for example, to green the warmth or the heating. Very often these hospitals are part of the urban network, and you can connect them to the heating systems in order to get green energy for these establishments. And one last example, the cold network. As you know, as health establishments, you consume a lot of cold ventilation, especially with climate change, climate warming. So we're talking about independent systems, autonomous systems that are highly greenhouse gas consuming. So if you get to a cold network, you can reduce the emissions of greenhouse gases by 40% and save on the bill. If I take the example of the Climespace network in Paris, in the beginning it was developed for comfort cooling, so to say, for the Galeries Lafayette, premium establishments, headquarters, etc. And now we're extending this to sanitary cooling system with nurseries, with kindergartens or social establishments. And we can see that in terms of savings, you reduce the bill by 15% for cooling these establishments. That's an average. And obviously with much more decarbonated cold system, which doesn't emit so much greenhouse gas. So these are the solutions that we can deploy in the short term. That hospitals have asked you to do? Yes, we've talked to the APHP and they agree. Étienne has talked about medications. The pharmaceutical industry, like all industries, has a carbon footprint. Do you know it? Well, if I can come back to what Étienne was saying earlier on, it's difficult to look at the issue in terms of data and figures. There's a lot of questions about figures, but overall, what we do know is that the pharmaceutical industry is not an example. I would love to come here and say, okay, we have set the example on all these topics, but it's not right. Overall, at global level, 52 million tons of CO2, which represents about 5% emissions, the equivalent of a country such as Switzerland, so quite a lot. But where does that place us? We're not as bad as the textile industry. We're not doing as well as cosmetics industry, but we're 15% worse than the car industry. You think that the car industry is not good. They're not good in terms of the use of their product. But at carbon level, the pharmaceutical industry, the manufacturing of medications, and I'm talking about the whole chain, from research to the selling of the medication, represents about 15% more than car industry. So when you think about that, you think it's a serious topic. And you have to realize that the good news is that the industry is now aware of this issue. For emissions in a period of 20 years, we have reduced our carbon balance by about 25%, reduced our water consumption, reduced by over 20% our gas emissions. So it's a question that is properly viewed and understood. The question is, was it due to new laws or individual initiatives? And the striking point is that it's the result of individual initiatives. And I'm very much struck when I look at the various groups. I can see what is being done. And in France, in Europe, companies have invested a lot to reduce their emissions, their carbon balance, to be water neutral, carbon neutral, with very specific objectives. A lot of big corporations announce that by 2025 or 2030 they'll be carbon neutral, and they'll be water neutral also by then. So massive commitments. Second thing, even though we have these progresses, even though we're taking care of that topic, which is a serious topic, at the same time it's rather complex for us. It's complicated. It's complicated for everyone. I'm not saying it's more complicated for us than for the others, but what I'm saying is that the quality chain, the regulatory elements that apply to medications means that every time you change one ingredient, one type of packaging, you have to revalidate, restabilize, get the approval again, and these processes can take up to 2 years. So it's not like you're changing the recipe of any product. You have a whole thing behind it that makes the process much longer. So yes, we have a strong carbon footprint. Two, secondly, the groups really are aware of the topic and investing a lot in this, but there is a specific, which is that it takes time because medications are different.
And do you quantify costs in terms of percentages? No, I couldn't give you that figure. But there's a second aspect, but I don't want to monopolize the floor here. You can talk about carbon footprint, and it's obviously an important topic, but it's much broader than that. The footprint is much beyond carbon, and the drugs have these characteristics. We say that there's more than 2,000 active principles used in drugs, but globally, in the water, you find between 80 and 90% of those. I heard the minister talk about biodiversity, but this is very serious. We can work on that, and we have to work collectively on recycling, neutralizing these active ingredients, and so on. So yes, of course, there's a carbon footprint for everyone, but we also have this footprint from the active principles and the products that we leave behind. Thank you very much. Mrs. Seroussi, we haven't talked much about the digital. It's often presented as a way of reducing the material footprint of the company. Probably so it is also for health, but it's not neutral. neutral in itself. It's true, the digital is often presented as a solution because it's immaterial, and as the Minister said, you know, the biodiversity crisis is immaterial, so we don't see it as much as the climate crisis. And it's the same for the digital. It's immaterial, it's not tangible, but it does have an impact on the environment that is not neutral. In 2014, there was a study, it was actually published in 2019, but it's really starting. It's only just starting. The data dates back from 2014, and basically the impact for the digital health, but all the digital, was more than 4% of greenhouse gas emission worldwide. So if it was a country, it would be 2 or 3 times bigger than France in terms of the total emissions. So the digital is not neutral in terms of carbon. Then what should we do? Digital in health, well, again, this will have a carbon impact, a carbon footprint. There's work that was done by France, by the DGOS, to try and see in university hospitals what could happen in terms of carbon footprint, and we saw that the carbon footprint of an average university hospital for their IT, not for the cloud, for anything else, was 5% of their global carbon footprint. The problem is that at ministry level, we promote the development of digital in health, because the digital in health assists prevention, it can cure patients, and it can save lives, because it will mean that patient journeys are easier, and it means we can share information between all the different players, it means we can coordinate different players, and so we need the digital in healthcare. But at the same time, there is an environmental impact. So there is this paradox that has to be managed by the health ministry. We need to promote digital tools because there will be benefits on health, but at the same time, we need to bear in mind that impact, and that carbon footprint has been estimated to cause 150,000 deaths a year because of climate change, and this should double before 2030. That's the figures from the WHO. So all issues with sustainable development, climate risk, biodiversity risk have to become obvious for everyone, and especially for the Ministry of Health, and I think we can talk about that again, and we obviously have some recommendations. How do you crack this problem, that one problem replaces another, that you use digital to reduce the footprint, but that the digital will cause other problems, even if those problems are lower? Well, there's 2 types of comments here. Firstly, I thought that the study of the impact of the digital on the healthcare system, it was very interesting, and we really look into this in France, so that's quite interesting. We are nowhere on the impact of our health services, except for the digital, which is quite paradoxical. There was a literature review showing that we need to move to telemedicine. We have a good carbon impact in that. We're talking about 1 million tons of carbon. That would be 1 million tons against 33 million. If we replace meat, if we replace the meat in the hospital restaurants, then that we can deal with that. That can be an easy way of dealing with this, but we have to ask the core of hospital networks. There is, for instance, the logistics of drugs. We have a logistics sector that is separate. That means that when you have to transport medicine, you don't pool transport compared with other logistical areas. There's lots and lots of regulations for good reasons. But if we had to think about the carbon footprint, we could think about removing the monopoly on the distribution of drugs. I'll give you another idea of putting carbon. What about grafting? When you get a graft, you get a plane that is specially that especially for that graft at night. Do we have to ask the same question when we have climate change on that choice as we would without the climate change? Not necessarily. I don't think it means that we shouldn't have air freight for grafts, but we might have to think about reallocating grafts differently. You can't think that you have the energy system worldwide on the one hand and the healthcare system that is remote from these problems. I took that question of grafts because it's obviously a painful one. And we have to think like that at all levels. If we isolate topics and if we think, okay, yeah, but the drugs are produced in the US and that's the only problem of carbon footprint in their healthcare system, then that's not the case. I was talking about the pharmacy tampon of plastics. It's not even a caricature. There are lots and lots of people going into pharmacies who are shocked by what they see, the amount of plastics. So we have to avoid this gap getting created. Jeanne, at the Curie Institute, there is a decarbonation plan. And do you have this decarbonation plan? Is it something that is cross-disciplinary? Étienne talked about kitchen. What about at Institut Curie? Have you removed red meat? Well, it's just like for all institutions. We have an obligation to lower our carbon footprint, minus 40% by 2030. And going back to what Étienne said, we are lagging behind. We are delayed for many reasons in the healthcare system. We have a supreme mission of looking after human beings. We're not producing cars, so we feel that we are remote from the question of decarbonization of our institutions and practices. And we saw it with the COVID crisis. It was no matter what, before the economy, before society, and maybe in terms of lives, it wasn't the right choice. But anyway, this question of health before anything else meant that we are lagging behind on other questions. And what you have to see is that there's the Lancet that publishes every year for 5 or 6 years now a report called the Countdown to Climate Change and Health, and the last publication was 2020. And the sentence that I'm thinking about is health crisis, climate crisis, both two crises in one. And I think this is what we realized during the COVID crisis, is that managing the climate crisis was the same as managing a health crisis. So acting to lower our carbon footprint, lowering the pollution of drugs and so on is the same as dealing with COVID and producing vaccines. Both things go hand in hand, and I think this is the realization we had at the Curie Institute and elsewhere. Our CSR was implemented this year. We have a plan that is being implemented now for our projects for the years to come. We recruited an engineer for sustainable development, so we are putting things in place. We're probably delayed from the English system, but nevertheless, we are moving forward. I agree with what you said, but maybe not quite that much. There are lots of individual initiatives that have been achieved in different hospitals throughout France. We have to reproduce this elsewhere. We have to follow what's being developed, and I think we've got this new impetus that we've had for 2 or 3 years now. In lots of industries, we know that reducing the carbon footprint is costly, and it's an investment initially, but maybe over time it might cost more than the normal functioning. But for medical companies, some indicators show that this might be different, and that you might have to invest initially, but a carbon-neutral healthcare system in the end will be cheaper. Can you tell us about this based on the energy side of things? In the end, yes, it does pay up. All the investments will generate savings, and at the end of the day, the bill will be lower. So you have to be clear about that. It's not just additional cost. Of course, you have to commit for the long term. I'll give you a concrete example. And it's true that things are moving in the hospital sector. We signed with the group of hospitals of Vendée a contract, which is an 8-year contract, to reduce their greenhouse gases emissions. So basically, the energy consumption. We commit to 20% for 8 years. That would be minus 20% until 2030. And the electricity will be 100% renewable with solar and hydroelectricity. So green electricity for the buildings. And they wanted a fixed price so that they wouldn't have variations. Again, we are going to have to commit. Obviously, it costs a little bit more, but at the end of the day, they're going to have a global saving of 17% on the bill. By when? Well, it's progressive. It's on average for the 8-year contract because the energy savings that we do are reinvested partly in greening the electricity and obviously will benefit to the building. And we are calculating the average. This is an average over the duration of the contract. So here we commit as operators to reduce the consumption and also to reduce the impact of CO2, and we have penalties if we don't reach the objectives. So greening means that you use what kind of energy sources? Well, we have energy contracts which are secured by green energy fleets. So hydroelectricity with the CHAM, for instance, which is a hydroelectricity company in the south of France, and we also have a solar farm in the Aube. So it's relocated. Yeah, it's not in Vendée, but you could sometimes have solar panels on the roof. This is not the case. It would never be 100% of the needs. We always need to source the energy from elsewhere as well. Thank you. Frédéric, you talked about non-CO2 rejects for the pharmaceutical industry. What do you mean exactly? I think the discussion is very interesting, and I think that we could learn as healthcare companies. There's one that we have to come back on, is the good use of the drugs. One of the, you have Cyclamed collecting non-used drugs. Cyclamed represents 11 tons of medicines a year that haven't been used. And Étienne is right. These drugs are incinerated in a special chain, but it's still incinerated, and it's just waste. It's bad use and it's waste. So we have a lot of work to do on the good use of drugs, first of all. And then second element, and we can't just forget the crisis we've just gone through. You talked about cure against care earlier. What we can do in terms of prevention is going to avoid the cure side of things. So everything we can do to prevent antibiotics, firstly, we know the effects in terms of antiviral resistance, will be a way of having some better use of drugs. And then the third element, and I think this is also very interesting, is how far can we go? Do we want to go? We were talking about score earlier. Would we have a score on drugs when it is being assessed, for instance? Say you have the benefits risk for the therapeutic aspect. Could we have an environmental score, traceability, sustainability, and durability? And what would we do with that score? And I don't have the answer, because let's imagine that an authority might say that in terms of product efficiency, yes, it means you have an ASMR this and an ASMR that, but your environmental score is this or that. And so, yes, it means we need to work on these drugs so they don't have such long-lasting footprints. But I think it's interesting to think, would we be ready to recognize this footprint, and should it be health no matter what, or do we have to include this dimension in the way that we develop and we assess the treatment more than the drugs themselves, because biotech is, I mean, it's 50% of pharmacopoeia, but it's not just drugs in terms of pills, it's more drugs that have other forms as well. And are we ready, and what would be the conditions? So we could imagine that with the same efficiency, we could choose the least dirty drug, but when would you be ready to have a footprint of your drugs, including clinical trials? If you do a clinical trial in 50 countries and 300 centers, well, if you work on all of the chain, on the value chain, our footprint starts with research, then you've got clinical development at hospital, and then you have manufacturing, and then in the cycle of the drug at the patient, and then in the good or bad use. We work a lot on all the carbon footprint side of things, so everything I said, how we can reduce by 2030. I think when I look at everything that's been done, there's very strong commitment done by groups, and I'm very impressed by this fertility. And there's something that I was thinking about that is a bit of a parallel, and it should give us some... of course, everything we say about the climate is worrisome now, but I think that we've gone through a surprising 18 months. If we'd been told that in under a year we would be able to vaccinate half of the world population and develop a vaccine and vaccinate half of the world population, nobody would have believed that. And I think that this is this was human genius. And yes, this crisis is something that we might have seen for a longer term, but it is in a way like a pandemic, and we might be able to find some quick answers. And I have trust, I have confidence in human genius in tracing molecules and their efficiency, for instance. This is also the care system today, beyond the digital or with the digital. What is the project to keep going to something that is less impactful to the environment?
Let me pick up what was said just earlier. As you said, convergence of crisis. We're right away in the topic of One Health. All these crises are, in fact, one crisis expressed differently. And what I meant to say is that whatever the cost might be complicated in terms of health, because the Shift project is a think tank in France about the environmental footprint, and they prepared a report, Let's Decarbonate Health, to be able to take care of people, to treat people for a long time. I'm not going to be to talk about disaster, but someone talked about that very well yesterday. Let's stop being negative. But it's a huge amount, and there's a positive dynamic, a positive movement, but with only a handful of good students. And then next to that, the rest of this class is not following, is not doing the same. And I agree with Étienne Grasse on this topic. When we realize now that it's really not a priority for health establishments or for editors of digital solutions. It's not a priority for them to try and protect, to preserve climate, or to try and introduce the right action in terms of carbon and environmental footprint. So, picking up on what I wanted to say earlier, for the ministry, we want to deploy the digitalization for health, but we have to be careful. First of all, we must use digital sobriety, meaning that we have to use the digital possibilities, but for good reason, look at how tools are developed and look at pertinent care, pertinent therapies. We must give the right care at the right time to the right patient. To mention Agnès Buzyn when she launched the National Health Strategy at the beginning of her mandate. And we have to make sure that we do not carry out systematic complementary workups or systematic imaging examinations, etc. We have to have the right system, and we must develop the code of digital solutions differently. A lot of people are getting mobilized with a green code in order to reduce more the environmental impact. Small example, which is not part of health. Microsoft, with their Bing browser, decided only to give back the top 20 answers. And they divided by 2 the use of the browser. It's useless anyway. No one goes beyond the 20th results. So when we talk about sobriety in the digital, it's just work on what is useful. What does the government and the Ministry of Health do? They build eco scores. There are 2 that are presently being organized. One is already finalized, one for the environmental impact of health applications. It will not be stop criteria for the health applications where there'll be because by 2022 there'll be a personal space for patients, and a catalog of services has been selected with applications selected, as I said, by the Ministry of Health, and there will be an eco score. It will not be a no-go. It will just be a public indication. If you have 2 applications for diabetes, the health system users can decide on one because it has a lesser carbon impact. The second eco score that was finalized is that of the environmental impact of on the hospital information system. And this is aimed at joining the certification system for hospitals carried out by GGOS called Maturin certification. It will not be a stop and go, a go, no go. It will be something that can be used for certification. I believe that you should have the right tools because otherwise it doesn't mean anything. You have to make the results public, and then you have to mean that you have to decide that when it's above or below a certain threshold, it will stop the application, for example. I'm not sure it will be work for CAPGEMINI, I guess. I'm not sure we understood the right system. Is it, how can you use a system for a hospital? Let me give you an example. In my previous life, I was in charge of working on building the North Hospital in the north of Paris. And the topic was how can we plan a hospital for 2025? And there were 2 challenges. First of all, at technological level, what will the hospital will look like? Some CEOs said by 2025, the hospital of the future will be no hospital. But, you know, those who worked with us, like Beaujon and the best departments in the world, in France, said, well, you didn't need an hepatology department in the hospital, Northern Hospital. So it's difficult to plan the future at more than 2 or 3 years ahead of time. and with a health system which is really overflowed with technology, it will also be overflowed by ecology. So you're going to have to use the technology and then find the right balance for carbon, for example. So you can use labels, you can use electricity. What you have to say is that there's no free lunch. There's not one place where you do not have the question of the carbon footprint. Getting rid of meals in hospitals represents 1.1 million tons or 1.5 million tons of carbon impact. And meat in the food in hospitals represents 1.5 million. The only solution that you have if you want to win at economic level, but not only, but save lives and get better well-being for the population, the only solution you have is to introduce the carbon issue in all your processes, well, whether it be medication production. I read that out of 180 medications produced every year, 6 or 7 are produced in France, for example. So you have mechanisms that reveal the carbon impact, and it's the best way of improving your processes. As you would say much better than we can, the economic balance will enable us to develop a new form of economic activity, smart grids for the northern campus. The new hospital will have activities for hydrogen, green hydrogen. You have to see things at the level of the French economy overall. The balance will always be good, and health will be well served if the French economy works well. Thank you very much. 40 seconds. Jane, in a hospital, does the procurement department look at the carbon footprint of suppliers and not only at quality? No, it's really on a... every time it's different. Some people have introduced specs with environmental clauses. For medications, we are waiting impatiently for this score in order to be able to choose the treatment that has the best environmental impact if we have 2 equivalent treatments. But it's not yet routine. I hope it becomes. And to answer the observation about energy and the cost of implementing these projects, there has been a study showing that any euro spent to reduce the environmental footprint has a direct impact on health, which is a message you can give your hospital managers. When they spend for the environment, this improves the health of people, and when this takes us back to the logic of prevention and the use of the health system. Thank you very much. We have to stop at that. Thank you for coming.